Hello, everyone. I'm Mark Plaster, Senior Executive Editor of Emergency Physicians Monthly, and you're listening to EP Talk, the place where emergency physicians, aka ER docs, come to talk about things that are important to us, both professionally and sometimes personally. And today I'm absolutely delighted to have as a guest Dr. Jarvis from England, Leeds, England. And we're going to be talking about traumatic brain injury biomarkers, something that I've been looking for a long time. I have the opportunity here in Annapolis to be the medical director or the medical physician for the United States Naval Academy boxing team. And so TBI is very important to us medically, and obviously the Navy doesn't want our future leaders to go into the service with brain injuries received as a student at the Naval Academy. So it's very important for us to be able to document what's happening in their sport. So, Dr. Jarvis, thank you for joining me today. We're talking across the pond to England. And tell me a little bit about yourself and how you got into this discussion of TBI.
Sure. Hi, Mark. So yeah, my name is Paul Jarvis. I am the Director of Global Medical Affairs for Abbott Point of Care, but also I'm still a practicing emergency physician. I have over 20 years experience as a frontline physician working in emergency departments in the UK. My interest in clinical practice is in neurological emergencies, so stroke, head trauma, those kind of issues. And I joined Abbott around 5 years ago and got involved in their TBI program.
Well, that's great. That's fantastic. And today, I want to. We have to. There are products on the market currently that measure biomarkers, but the discussion today is on some different biomarkers that may be coming out, and we're not talking about a product. We're talking about an approach, and I wanted to ask you, when you're looking at TBI, what are the challenges that you see that are associated with mild TBI? We all, as emergency physicians, we all see all these people who have bonked their heads, and we look at them and we say, chances of you having a CT provable injury is limited, but that's not the end of the discussion, is it?
No, I think that's a really important message. I mean, we do see a lot of patients who've had a knock on the head, and it's our, as emergency physicians, it's our role to decide who's got an intracranial lesion and who's just got a damage to the outside of their head. Yeah. And it's not that difficult when you've got someone with a reduced level of consciousness. It's a relatively straightforward decision, but it's those grey cases on the boundary where does this patient have an intracranial injury or have they just got a minor head trauma? And it's often a very difficult decision whether to scan someone or whether to just rely on your clinical judgment and say, no, a scan isn't indicated. And then you have other conflicting pieces of information. Maybe the patient has dementia, which makes it very difficult to get a baseline on their mental state. Or perhaps they're intoxicated with alcohol or other substances. Or perhaps they don't even speak English as a first language. And all these things make the decision to CT or not CT very, very difficult. And so it just makes the diagnosis of mild traumatic brain injury very, very hard for the emergency physician.
Yeah, and in my situation, when I see patients with head injuries, and not just whether to CT them or not, the CT itself, yeah, sure, you don't have an intracranial bleed, you don't have mass effect, you don't have a fracture, but does that mean that you don't have injury? You see, I think oftentimes our negative CTs are misleading.
You're absolutely right. So a negative CT tells you that the patient probably doesn't have a neurosurgical emergency.
Right.
What it doesn't, what it misses is the subtle brain parenchymal injury, where the patient could have significant functional problems, but the CT would be negative, and it would only be picked up on an MRI scan. And we don't routinely MRI our head injury patients.
Right, right. I mean, if MRI was available to every single bonk on the head, maybe we would get this information, but that's practically impossible, and certainly in a system that's trying to be financially responsible, you can't do that. So
No, and our departments would grind to a halt. The patient flow would be non-existent because the time to get a reported MRI, it takes forever,
yeah.
and so yeah, it's not practically possible.
Yeah, and a lot of times, we end up saying, okay, go back to your doctor, or if it's a significant, we have concern, then we'll may schedule an MRI. But really and truly, they want to know now, and isn't right now the time that the biomarkers for TBI start to appear and could actually give us some usable input?
Yeah, there are many neurobiomarkers, and they all have slightly different kinetics. So there are those that rise up very quickly, like UCHL1, which goes up in the first 30 minutes or so following injury. And you have other biomarkers which rise slower but stay up for longer. So they may be up for a couple of hours or maybe even for a couple of days. And so it's knowing which biomarkers should be up in the time frame of the patient you're using. And this is not information that most emergency physicians are used to dealing with. If your clinical practice is anything like mine, I've never used a neurobiomarker. I've
Right.
used biomarkers for troponin in heart disease, and I've used biomarkers for D-dimer in pulmonary embolism, but I've never considered it for a head injury.
Yeah, and that's exactly right. That's the reason why I was so excited to see this, because I've been in practice long enough that with biomarkers for MI, heart in the myocardial infarction, occurred in my clinical career, and it was such a game changer to go by. Okay, you look at in STEMIs, you look at that, the EKG is not changed, but the troponin when the troponin pops up, then you know what you have. But it's a very similar analogy to have somebody hit on the head and say, okay, I don't see anything here, but do you in fact have an injury that we should be aware of and should be tracking and that sort of thing? And the idea of having neurobiomarkers it's a game changer. But tell me, okay, educate me on the various neurobiomarkers that are out there and the ones that you think that we should be tracking.
Yeah, so there are many. So probably the most widely known neurobiomarker would be S100 beta. Commonly used outside the US, seen a lot in sort of Scandinavia and Northern Europe. The trouble with a biomarker like S100 beta is it's affected by non-head trauma. So if you have orthopedic trauma, your levels will rise, which can often be misleading in the context of some of multiple injuries. But also it's secreted by your melanocytes. And so if you have any ethnic diversity in your population, then you're going to get some wayward results. And so it's not as reliable as people would like.
And you're saying S100 beta, your English accent. I want to get this right. S100 beta.
Okay. Yeah, that's right.
Yeah,
sorry.
That's okay. That's okay. I'm just being an American here, and I'm just trying, with my American ears, I'm trying to make sure that I'm understanding this correctly. S100 beta, because I want to follow this up. We're gonna be doing some written material on this as well, and I hope to work with you to develop some of that.
Sure.
But you're saying that S100 beta is like the CPK, if you will, of cardiac. You want something that's unique to the brain and not in bones, not in skin, not in other areas that could be misleading or give you a false sense of security or overreact or any of those things. So what else besides S100 beta?
So there are two new kids on the block, really. There is GFAP, glial fibrillary acid protein.
Whoa, do that again.
Glial, so it comes from your glial cells, fibrillary acid protein, so GFAP. It's best to use the letters because the names get more convoluted as time goes by.
Okay.
So GFAP is found in your glial cells, the astrocytes, the supportive structure around your neurons. And this kind of rises over the first hour of injury and stays elevated for, maybe up to 12 hours or even longer. And this has been shown to be associated with acute injury. So it's a really promising biomarker. Right. The one that goes hand in hand, which I mentioned briefly earlier, is UCHL1. They're not very catchy names. I think we need to work on the names more than anything. But UCHL1 is found in the nerve axons. and these levels go up within 30 minutes of injury. And they're only up for a couple of hours, but it helps you identify those ultra acute injuries, whether early presenters that come to the ED that can often be problematic. And I think a combination of two biomarkers, UCHL1 and GFAP, is probably the best way of identifying who has a brain injury and who does not.
Yeah, and this is specific because of its early appearance, 1 hour to 12 hours in GFAP and 1 to 2 hours in the UCHL1. This is the domain of emergency medicine. This is
absolutely.
You're not going to see this when it comes to the office 2 or 3 days later, or you're going to be blinded by it. The only people who are going to see this is us.
Well, there's lots of work at the moment looking at the clinical utility of these biomarkers, and yeah, the early acute phase, the area where we play, is absolutely the key use for these biomarkers. But there is some interest in using these biomarkers for tracking recovery or maybe tracking prognosis. And so how long they stay up at the absolute level they're elevated to all becomes very, very important. This is all experimental work. This is all just sort of early level publications, but it's really, really exciting.
Yeah, but that's where EP Talk and emergency physicians are right now. We want to be on the leading edge of this and not reacting to it when it comes out. Talk about the impact of head injury on the emergency department. I mean, you and I have been around long enough to see thousands and thousands of head injuries, and you can't CT each one of them, or you can, but it contributes to the gumming up of the emergency department when all these people get with CTs. Then you have to deal with all the people who are looking at you saying, well, you can't tell me whether I have a head injury or not. You know, I really got hit. It was hard. Were you knocked unconscious? Well, maybe. You know, I got my bell rung for a little. You know, and an employer wants to know. I mean, is he harmed? I mean, tell me about the impact that you've seen, because you guys have done some statistical studies.
Yeah, so it's really fascinating. We see a lot of patients, as you say, we can't CT all of them. And so one of the key things that we see is the introduction of guidelines. Should I CT or should I not? And there are myriads of guidelines, whether it's the Canadian head CT guidelines or the ACEP guidelines or the New Orleans criteria. And these are great. These give you some kind of structure to work with to say, should I CT, should I not? But the problem with guidelines, they default to safe, so they promote over use of CT just to be defensive, so we don't miss an injury.
Right.
And because at the moment we're stuck between a rock and a hard place. We either have nothing or CT. Once we've done our clinical assessment, we can either CT or nothing. And so, you know, what we see, particularly in inexperienced doctors, is they default to CT because then they know for sure. Right. When you get a few more years under your belt like us, we might rely on our clinical judgment a little bit more strongly. But ultimately, CT is our only real option. And when I see biomarkers coming in, it really will help us. You've got to remember that 90% of head injuries are mild, by which I mean they'll have a GCS from 13 to 15, and most CT scans done in this group will be negative.
Yeah. You know, how many times, you know, you cut your hair off, but I've got gray hair, you know, and I'm able to say to people, you know, I've been doing this a while, and I've looked at thousands, truly thousands. I wrote a book one time, so we did an analysis of how many patients I'd seen in my life, in my career, and it was approaching 200,000. And so I have the gravitas to say to a patient, in my experience, you know, we don't really need to scan you, you know, that doesn't meet the rules. They trust me, okay? But in my mind, I'm looking and saying, you know, there could still be injury here, and I just wouldn't see it on CT. So whether they have a CT provable injury is not the end of the question. That's the point. That's the point you're trying to make here.
Oh yeah, no, CT is great for looking for neurosurgical emergencies. It's looking for bleeding or contusion, those things which the neurosurgeons like to keep an eye on. It doesn't look for brain injury itself.
Yeah.
You know, and that's where the MRI comes in. And so it's all back to good quality. You know, my tutors at university be proud. It's still our skill set is history taking.
Yeah.
A good history is where you make the diagnosis.
Yeah.
You know, the other things confirm or exclude what you thought, but ultimately your decision making is your diagnosis. And I think biomarkers are going to be helpful because they'll help us standardize our approach to these patients.
Right. I was just going to ask you that because, as you know, I've worked all over the country, and imagine you have experience in smaller facilities, and so the care rendered in a smaller facility is not the same care that you would see in a major tertiary care center. So our goal here is to make sure that everybody gets, you know, the top level of care, and that really doesn't happen. Oftentimes there's inconsistency between the care rendered at a university like where you practice that has neuro emergency physicians and your average ER, and looking at they may not even have access to MRI. And
no, you very much so. I mean, so I've worked in level 1 trauma centers, level 2 trauma centers, and small cottage hospitals in the middle of nowhere.
Yeah.
And these patients present to all of those facilities. The patient doesn't know any different. They go to the nearest hospital, expecting to get the best level of care. And so we owe it to our patients, I guess, to be able to have these kind of tools in every facility to identify two things: those patients who potentially could have a brain injury, but also identify those patients who don't and can be discharged.
Yeah.
And those two things are really important decisions, which when you only have history and examination, there's a huge gray area there. Which is this patient? Because as you say, they've all been knocked on the head. They've all been busy for a little bit. And so it's how do you balance those two things? And so biomarkers just helps guide our decision making.
Yeah. It's like it's like interpreting chest pain. You talk to some people, you say, how much does your chest hurt right now? And they look at you, and there's not a twitch, and it's a 10. It's a 10 out of 10. Mm-hmm. And you talk to some miner or farmer or a guy who's had pain his entire life, and you say, how much pain do you have in your chest? And he says, it's a 3. And then you turn out he's got a giant high grade lesion, and he's having left main disease, and so sometimes as good a history, and I'm a good history taker, I suspect you are too. The history just is not able to do the objective kind of stratification or screening that we would like it to be able to do.
No, and what you're describing there is the value of experience, knowing that the minor will say 3. The teenage boy will say 12. Those things we know. And so, this just gives you that level of objectivity that we currently don't have.
There was some specific research that you sent me some information here talking about the 2018 ALERT TBI study from Bazarian, published in Lancet. Talked about some biomarker tests. Can you tell me a little bit more about some of that research?
Yeah, so the ALERT TBI study, as you say, was published by Bazarian in 2018, and it looked at specifically the UCHL1 and GFAP biomarkers in tandem. And the study showed incredibly high sensitivity. We're talking about 97% sensitivity and a negative predictive value of around 99.6%. These are really high numbers. Wow. Yeah. So what we're describing there is a perfect rule-out test. If your test is negative, your patient does not have a brain injury.
Yeah.
And so imagine putting that into the hands of a frontline clinician who's got a waiting room full of people who've banged their heads. Who do I CT? Who do I not? This is the group you don't need to CT.
Right.
And Bazarian and his colleagues said that 35% of CTs potentially could be reduced if we introduce these biomarkers.
Yeah. And I hate to always say, I keep coming back to this because as we are trying to reduce the overall cost of healthcare, one of the things that we, and I hate to use the word unnecessary because it's necessary if you don't have a better tool. Okay. So, But the question here is, how many CTs do you actually need to do? What we should be we should have CTs for only the people who actually need them, or at least the negatives should be significantly less. And I look back at the numbers, and you say that 82% of CTs are negative. Head CTs are
Yeah,
negative.
yeah.
82%.
Yep.
Geez. I mean, you know, and that's a lot of money.
That's a lot of money and a lot of time. And remember, in the ED, time is everything, because you've always got a line of patients waiting to take the next bed. And so yeah, it's if you can reduce CT by as Bazarian says, 35%, that's astonishing. The flow through your department will be palpable. Yeah. Okay. So when you get damage to the brain, the cell gets distorted by the forces that are causing the damage, and this leads to the cells being injury, releasing these biomarkers. The blood-brain barrier gets leaky, and so these then pass over into the circulation. And so we can measure them very quickly in the circulating peripheral blood, very shortly, like we said, after injury. And I think that's the secret to these working, really, is that they have to be measurable in peripheral blood very soon after injury. They have to be sufficient sensitivity to be able to make a diagnosis of TBI, or certainly assist in the diagnosis of TBI. And also the biomarkers, you've really got to be focused specifically on head trauma. If they go up in other forms of trauma, it becomes less useful as a test. Because if you've got a patient who's been involved in a motor vehicle collision, has multiple injuries, if your biomarker is elevated because they have a leg fracture, it's not going to help you in terms of looking after their brain.
Right, right. So I was sort of taking some notes here. So the three major criterion you have for an effective biomarker, I wrote down, is that the biomarker must be detectable in peripheral blood shortly after injury. Okay,
That's
is that right?
Yeah.
And that the sensitivity of the biomarker must be high enough to detect even a mild injury. And
yes, I think that's important. I think that's really important, that it's mild injury.
Yeah.
You know, severe injury is relatively easy to diagnose. Mild injury is where the gray, difficult area is for the ED physician.
Right. And then the elevated biomarker has to be specific, and you mentioned that. We don't want we don't want to be confused with something else. Well, this is truly amazing, and this is work that research that Abbott is doing. I want to talk a little bit about Abbott's. The website is called tbibreakthrough.com, and when you get to there, there's a lot of discussion of TBI, which we'll probably give to you in subsequent issues of Emergency Physicians Monthly. It discusses the challenges involved in evaluation, patient care challenges, discussions of biomarkers generally, research and update. There's a lot of different stuff here. So I think that we're starting to scratch the surface of what this can be, and I'm excited about it. That Emergency Physicians Monthly and working with Abbott will be able to keep, as soon as other things are available, as you say, some of these are available in Europe. They're not available in the United States at the current time, but hopefully soon we might have something like that.
Yeah, I hope so. It's exciting times. To be on the forefront of this kind of research is really an exciting place to be.
Yeah, exactly. Well, Paul, thank you so much for joining us today. Do you have any last comments to make before I sign off here?
Yeah, I'd like to just reiterate one point which we said earlier, you know, that a negative CT does not rule out brain injury. You know, 50% of patients with what we would deem as a mild injury will have symptoms for more than a year. And so bear that in mind when we assess these patients, because if a patient has a negative CT, they can still have a significant life-changing injury.
Yeah, no, I think that's a very important point to make, and I think that a lot of patients are very frustrated with us because we've sort of blessed them to say your CT is negative, you have no injury, and then a month later they're still having headaches, they're still having problems, and they're saying, but he told me that I had no injury, and it would be so much better if we were more accurate with our assessments so that they could get into post-trauma care and rehab or whatever is necessary for that particular injury. So that's a very, very good point to make. So again, thank you, Paul, for joining us, and thank you for Abbott Labs for making you available to us. And we will stay in touch, and we're going to continue to discuss this development as it becomes more widely available, and as the research is as more research is being done. So thank you, and for those listening to EP Talk, I hope you've enjoyed this afternoon. Talking across the pond to our friend in England, and we'll try to do this again sometime. So thank you, and thank you for joining EP Talk.